So we'll continue with the endocrine system. So now we are going to do the suprarenal gland, the pancreas, and the pineal gland. So let's look at the suprarenal gland. Now this has two distinct areas. The outer shell is called the cortex. So the outer shell is known as the cortex, and you have an inner medulla. They produce totally different hormones, which obviously have different functions. So we'll concentrate on the cortex first. And in the cortex, the areas, it's divided into zones based on, the names are given based on how the cells are arranged, and the hormones produced are different. But you'll notice some similarity. One, they all have the word zona attached to it, which means, they form a particular zone of the cortex. The second thing is that all of the cortical hormones are corticosteroids. So they are all corticosteroids. That means they begin, they're steroidal hormones, and they are formed from cholesterol. So that's kind of the initial pathway. And so that's why it's important, sometimes people go on an absolutely no-fat diet, which is not really good, because you do need fat for a lot of things in your body. One of these, as you can see, is the steroid hormones. The other is, like plasma membranes, things like that, okay? So they produce, all of them produce corticosteroids based on which part is more predominant, and what the action are. We kind of name these corticosteroids differently. So let's look at the zones first. So the first one is called zona glomerulosa. So this is the outer zone, which is this area here. So it's this area here. And so it's this area here. And it's called glomerulosa because the cells are arranged, as you can see, like little circles or little balls. So that's what is the meaning of glomerulosa. It comes from, in the kidney you have a glomerulus, which is kind of round in shape. So looks circular. So that's how it got its name, zona glomerulosa. The hormones produced by this area act on the electrolytes in the extracellular fluid. So that's why, and these electrolytes are minerals like sodium, potassium, calcium, chlorine, all these, chloride, all these are electrolytes. This acts primarily on sodium and potassium. So these are known as mineralocorticoids, of which we'll see that aldosterone is the most predominant one. So aldosterone is the most predominant one. And we'll look at its actions. The second zone, this area here is called zona fasciculata. Fascicles are like little bundles, so that's how it got its name, little bundles. And if you notice, they kind of are arranged in a bundle-like fashion, this way. These produce glucocorticoids. So if you think of the word glucose, so it's something to do with glucose. So they are concerned with glucose metabolism, but they have other actions too. They are primarily the hormones which respond, which help you deal with stress in the body. And then we'll see other actions of these. Of these glucocorticoids, the most predominant one is known as cortisol. Then the third zone is a narrow zone which is known as zona reticularis. The word reticulum is like a network. So if you look at this, this looks pretty much like a network. The cells are kind of in a haphazard, arranged in a little bit of a network. So that's why it's called zona reticularis. It produces sex hormones or gonadocorticoids. So we can also call these gonadocorticoids, or also known as androgens. And then these androgens get converted to testosterone and a little bit of estrogen in the tissues. In fact, after menopause in women, this zona reticularis or your adrenal cortex is the only source of estrogen. So that was the cortical area. And then when we look at the medulla, which you can see here, this is the medulla. The cells actually have these are called sympathetic ganglion cells. So it is connected to the sympathetic nervous system. So they have sympathetic ganglion cells, or these are also known as chromaffin cells. And just like the sympathetic nervous system, this area produces epinephrine and norepinephrine, of which epinephrine is more predominant. And if you remember, when we were doing the various ways hormones were secreted, we did the humoral method where something in the blood caused a hormone to be secreted. Examples were, which you have done so far, parathyroid or calcitonin. Then we did the nervous stimulation, if you remember. So nerve impulses come and then they stimulate cells to produce the hormones. So this medulla is under nervous control. So nerve impulses will come from cells present in the brain and in the spinal cord. So it's under nervous stimulation. So those nerve impulses or axons will come and they'll synapse on these chromaffin cells in the medulla, and then these secrete epinephrine and norepinephrine. The cortex, if you remember, we were talking about something called corticotropic releasing hormone, which then caused ACTH or adrenocorticotropic hormone, right? And then that acts on the cortex. It acts mainly on the zona fasciculator, to some extent on the zona glomerulosa, but zona reticularis does not have, it's not influenced by this corticotropic releasing hormone and the ACTH, that chain. So let's look now at the suprarenal hormones. So the first one we are going to do is from the zona glomerulosa. As I said, they are called mineralocorticoids. The primary action is on electrolytes, and sodium and potassium are the ones that it primarily acts on. So what it does is the function of aldosterone is to make sure your blood volume and hence your blood pressure is maintained. So what it does is it causes whenever blood volume or blood pressure is decreased, this is when it will be stimulated, it will be produced. And it causes sodium absorption from the kidney tubules. And whenever sodium is absorbed anywhere in the body, if sodium is absorbed, water follows with it because sodium is osmotically active. So if sodium is thrown out of the body, water will follow it. You get that? If sodium is absorbed by the body, water will follow it. Okay? Because it's osmotically active. So that's what it does. It causes absorption of sodium. And because sodium is absorbed in the kidney tubules, water also follows it, and hence that will then be pushed into the bloodstream and your blood volume will go up and automatically your blood pressure will go up. So you can see how it helps to maintain blood volume and blood pressure. So it raises the blood volume and blood pressure. The main stimulus for release is, remember I said ACTH acts to a certain extent on it. The main stimulus for release is actually something known as the renin-angiotensin mechanism, and also sodium and potassium concentrations. Of this, potassium concentration is more important. So whenever there is a high potassium concentration, then aldosterone is released. And let's look at it, why this is so. So first let's look at the sodium and potassium relationship in tissue and extracellular fluid. So if you remember from ANP1, and just to give you an example, you remember we had a muscle cell. This is present for most of the body. So if you remember when you had a muscle cell, the outside of the muscle had more sodium ions, the inside had more potassium ions. Remember that? And then whenever a nerve impulse came and you had all that at the neuromuscular junction, it caused depolarization. What happens? Sodium goes in, right? So now the charge, the inside becomes less negative compared to the outside because you get more positive charges inside, and then that wave of depolarization goes. So after some time, sodium input influx is stopped, potassium goes out, and then you have the sodium potassium pumps which kind of reverse it, and you get back that whole, you get that whole ionic balance again. So based on this, what happens is sodium is the predominant ion in the extracellular fluid. So more of sodium is present outside, and more of potassium is present inside the cell. So you want this balance to always remain. If this balance is disturbed, if potassium is more on the outside, that means in the extracellular, outside the cell, then something is wrong, right? So that's when you can understand aldosterone will be released. Or if there is less sodium outside, that means the body needs that sodium, so again aldosterone will be released. So that's one factor. The other is this thing called renin-angiotensin mechanism. To understand this, let's look at what happens in the kidney. So inside the kidney, you have blood vessels which go into the kidney into a structure which is known as the glomerulus. So this is a collection of blood capillaries. And so there's an artery feeding into it, and there's an artery which goes out of it. So these cells in the muscle cells inside the artery, they are very, very special. They can sense blood pressure. So whenever the blood volume falls, let's say someone has bled a lot or somebody is dehydrated, what happens? Naturally, your blood volume will fall, so automatically your blood pressure will fall. If you have less fluid, your pressure will be less. So as that blood is flowing through the kidneys, these cells inside this arteriole, they sense it and they release a hormone known as renin or renin. This goes into the bloodstream and it actually goes to the liver. It travels to the liver where it activates something known as angiotensinogen. So this angiotensinogen, whenever you have the word gen, it is an inactive form. So it activates angiotensinogen and it converts it into angiotensin 1. So I'm just going to write this, angiotensin 1. Angiotensin 1 then travels and in the lungs and other tissues, but especially in the lungs. So I'm going to take this. So first we had renin acted on angiotensinogen. So I'm going to write it this way. In the liver, converted it into angiotensin 1. And then this angiotensin 1, as the blood is flowing in the lungs, you have something known as angiotensin converting enzyme. It converts it into angiotensin 2. Okay, so rather convoluted pathway. So the renin causes angiotensin to be formed, okay, and through this pathway. Angiotensin then goes and acts on the adrenal cortex, the zona glomerulosa, and it causes aldosterone release. When aldosterone is released, and remember what was the stimulus for release? Renin, because there was low blood pressure, because of low blood volume. So what aldosterone will do is it will reabsorb sodium into the kidney tubules, water will get reabsorbed with it, and it will automatically raise blood volume and blood pressure. And here can you see it is acting somewhat similar to ADH. You remember ADH was also secreted whenever the blood volume was low. And what ADH did is it only reabsorbed water and it raised the blood volume and blood pressure. So this has a similar action. The only difference being it causes reabsorption of sodium primarily and water follows with it. Whereas ADH acts directly on water reabsorption. Okay, have you followed that? In stressful times, so the main stimulus is this renin-angiotensin mechanism, and then as I said, the potassium concentration, so when it's high, or if the sodium concentration is low. During stressful times, that's when ACTH also acts on it. So you can see that ACTH is not right on top of the reasons for stimulus of aldosterone release. There is a hormone which is produced by the atrial walls, if you remember, called atrial natriuretic peptide. ANP. The hormone is atrial natriuretic peptide, and we did this in the endocrine system. We did this earlier when we were talking about the ADH. Natriuretic. Natrium means sodium because sodium has it's Na. So natrium means sodium. Natriuretic meaning passing of sodium in the urine. So if sodium goes out in the urine, what will happen? Water will also go out with it. Remember I said sodium is osmotically active. So can you understand that atrial natriuretic peptide would be an antagonist to aldosterone, a direct antagonist, because it's doing exactly the opposite thing, right? This aldosterone causes absorption of sodium and with that water, so it raises blood volume and blood pressure. ANP does exactly the opposite. It causes sodium to be removed from the body and passed out in the urine, and when sodium goes out, it draws water with it, so people pass a lot of urine. So ANP is an antagonist to both aldosterone and even ADH. So let's look at little bit on the functions of aldosterone and also the renin-angiotensin mechanism.
Aldosterone promotes the reabsorption of sodium and water by acting on the kidney, and this concentrates the urine and raises both blood pressure and blood volume. Reabsorption of sodium and water into the bloodstream by direct action on the kidney. As shown in this table, angiotensin-2 has a variety of other effects due to its stimulation of AT1 receptors. For example, it can introduce more fluid into the body by stimulating the hypothalamus of the brain.
Now here he talked about angiotensin-2. So what happens here, we only talked about aldosterone causing sodium reabsorption and with sodium water, so it raises the blood volume. But in the process of aldosterone being secreted, you also have that angiotensin because you have that renin and that angiotensin. When you think of the word angiotensin, what does that signify to you? What do you think it can do? What could be one of its other actions apart from causing aldosterone to be released? What could angiotensin do? Just by the word. Remember we had ADH was also called vasopressin. Like that, this angiotensin. What do you think it can do? Angio means blood vessel. Constricts the blood vessel. Exactly. Tensin meaning tenses or constricts. So angiotensin by itself also constricts the blood vessel. So can you understand when blood vessels are constricted, what happens? Peripheral resistance increases, so it raises the blood pressure. And I mentioned ACE, and just as out of interest, you may have heard of people who are hypertensive. They have high blood pressure. They're often given drugs which are known as ACE inhibitors. Okay? That means if you have anything which will inhibit this angiotensin converting enzyme from acting, what will happen? Angiotensin will not be produced and hence you can bring down the blood pressure. So that vasoconstriction is not going to happen in that case. At least you help vasoconstriction from not happening to a certain degree. Yeah.
So because the angiotensin converting enzyme is found in the lungs, that's why these inhibitors can trigger cough?
Can trigger? Possibly that and ACE inhibitors can trigger cough. It's possible because most of the ACE enzyme is present in the lung, more of it. So it's possible. Maybe it causes constriction there and less blood supply. And I have to check up on that one. But possible, could be. Okay. Okay. Let's look at this renin-angiotensin mechanism now, just as a review.
My lower back pain, it was almost unbearable. Any doctor that
Renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system is a classic endocrine system
that helps to regulate long-term blood pressure and extracellular volume in the body. The system begins with the release of angiotensinogen into circulation by the liver. This may be in response to low blood pressure and adverse changes in sodium concentrations. An enzyme, renin, is secreted, which cleaves angiotensinogen to form the inactive decapeptide angiotensin-1. Further transformation of angiotensin is carried out by angiotensin-converting enzyme, or ACE. This is predominantly found in the pulmonary circulation. However, ACE is also produced in the vascular endothelium of many tissues, including the kidney, adrenal gland, brain, and heart. The angiotensin-converting enzyme converts the inactive precursor angiotensin. Alternative pathways exist that do not rely on either renin or ACE. In non-renin pathways, enzymes like tonin and cathepsin D release angiotensin-1 from angiotensinogen and tissue plasminogen activator, or TPA, and can make angiotensin-2 directly from angiotensinogen. This bypasses the midway production of angiotensin-1. Enzymes like kinase can form angiotensin-2 from angiotensin-1 via an ACE-independent pathway. Angiotensin-converting enzyme also degrades bradykinin, which is required for synthesis of a major vasodilator, nitric oxide. Angiotensin-2 binds AT1 receptors expressed on the surface of vascular endothelium and impairs nitric oxide synthesis as well. Reduced bioavailability combined with the stimulation of AT1 receptors on smooth muscle cells causes vasoconstriction. In addition to a vasoconstriction effect, stimulation of AT1 receptor causes the adrenal glands to release the hormone aldosterone, resulting in sodium retention. Combined with vasoconstriction, this increases blood pressure. In the final stages of RAS, the kidney reduces the production of renin.
So, I mean, it gave a little bit extra, which you don't need to know all about the other enzymes acting, but you can see how that whole system kind of works and how aldosterone is released, and both aldosterone and angiotensin then help to raise the blood pressure and blood volume. The next zone is zona fasciculata. Like I said, it means little bundles. So here this zone secretes glucocorticoids, of which cortisol is the most important one. This is the zone which is primarily under the CRH-ACTH pathway, so corticotropic releasing hormone and then ACTH, and then acts on the fasciculator, produces glucocorticoids, and then, there's a negative feedback control. That feedback is overridden in times of stress. So let's look at some of the actions of cortisol or these glucocorticoids. When they are present in optimal levels, they help your body deal with stress. So, all the things that you need. So what they help do is they help maintain blood volume and blood pressure, because they make your blood vessels more sensitive to epinephrine and norepinephrine. So that's how they make it, they help to maintain blood pressure, and they help maintaining blood volume. In fact, when somebody collapses or has a very low blood pressure, one of the first things you give them is steroids, so that you make these peripheral receptors very sensitive to epinephrine and norepinephrine. So for some time, you kind of help to raise their blood pressure. So that's the use of steroid that we have. Again, under normal circumstances, it maintains your blood sugar levels. And it does this by making sugar from from non-carbohydrate sources. So that process is known as gluconeogenesis. Gluco meaning for glucose, neo meaning new, genesis means to make. So gluconeogenesis is to make glucose from non-carbohydrate sources like lipids and proteins. So that's what it helps to do. It kind of mobilizes fats and proteins, so it kind of causes lipolysis, breaks down, and that's how when it breaks down lipids, that's how it helps to make glucose. It also helps to break down protein, and in normal circumstances that breakdown is used for enzymes and for repair of tissues. It has an anti-inflammatory, anti-immune action. So how it does that is it decreases mast cell numbers. If you remember, mast cells were important, so it decreases mast cell numbers and macrophages. It reduces capillary permeability. It depresses phagocytosis. So let me write that down. So depresses phagocytosis. Decreases mast cell numbers. It reduces capillary permeability. So you can see how all of these would, depress inflammation and also would be an anti-immune response. Now, at normal times, whenever, you're functioning well, usually your cortisol levels are highest when you wake up in the morning. They're lowest when you're kind of sleeping, and they do all of this, kind of keep your body running very, very smoothly. But sometimes when the levels really go up, and they are produced because they help your body deal with stress. So when you're acutely stressed, or even if you have chronic stress, the levels of cortisol keep, going up. So then there is none of that CRH, ACTH negative feedback is completely overridden. So then you see the side effects of having too much cortisol in your body. And we'll see that in one of the conditions called Cushing syndrome. Okay. One of the uses I've already told you, because it makes your riscatecholamine receptors sensitive to epinephrine and norepinephrine. You give it when blood pressure falls. Another thing is it also helps, and since we have done the respiratory system, one interesting fact is it actually increases surfactant production. So in premature children, when they are in their incubators, because they are not producing enough surfactant, we kind of give them corticosteroids again to help them to produce surfactant. So these are some of the uses. People with allergies, graft, when you give someone a graft and you want to prevent rejection, then again you give corticosteroids. Like someone suffering from any autoimmune disease like rheumatoid arthritis, multiple sclerosis, we often give them steroids. Again, whenever there's a graft and you want to prevent rejection, we give this because they have an anti-inflammatory effect. So that's why you give it. But then it also ends up with some side effects because their immune system is depressed. These people are more prone to infection. So, you have to kind of weigh the pros and cons. So let's here just review aldosterone secretion. So here are the primary regulators. So you can see the renin-angiotensin system here. So if your blood volume or blood pressure has fallen, the kidney senses it. Those arterioles, which we'll do when we do the urinary system, they secrete renin, and this goes through that whole cascade and produces angiotensin-2, which acts on the zona glomerulosa producing aldosterone, which will target the kidney tubules. There'll be increased absorption of sodium, and with it water will follow and potassium will be excreted because you've got to keep that balance. So your blood volume and blood pressure increase. Or if there is an increased potassium in the blood, that means in the extracellular fluid, obviously you want to get rid of it. And aldosterone is the hormone which does that. So again, that can do this. And then we have other factors where, for example, if there's increased stress, then you have the whole corticotropic releasing hormone and ACTH, and then that goes and acts on the zona glomerulosa and produces this. And here you can see that if you have the opposite situation where your blood pressure or your blood volume has increased, let's say someone has high blood pressure or too much fluid in their body, then the body's natural system will cause ANP to be released by the heart, the muscles, atrial walls, and so that will inhibit the zona glomerulosa, and in turn it will cause excretion of sodium. With that, water and your blood volume and blood pressure will fall. So you can see how these both these hormones are kind of antagonistic to each other. So let's answer this question. Okay, need a couple more. Yes, very good. Like ADH. The one difference, of course, was ADH acted primarily on water, but remember, ADH was also called vasopressin, so it by itself also it caused vasoconstriction of blood vessels. Aldosterone can't cause any constriction of blood vessels. It kind of depends on angiotensin to do that. Okay. Okay. Here again a quick review. Well, I've got two choices here, unfortunately, but I'm talking about the main and the first stimulus. Okay, the first stimulus is renin-angiotensin mechanism. That's the first one. And then there is this high potassium levels in the extracellular fluid or low sodium levels in the extracellular fluid. Okay? Okay. Okay, a couple more people. A and P, yes, very good. Okay, let's look at the suprarenal, zona reticularis, the last zone of the cortex. So here it produces gonadocorticoids, which are also called androgens. And they get converted into testosterone mainly and some estrogen. And as I said, that after menopause in women, this is the site for estrogen production. They think that these gonadocorticoids probably control the onset of puberty, like, the appearance of a beard or axillary and pubic hair and so on. But otherwise, testosterone is produced more adequately by the testes, and the ovaries produce estrogen and progesterone. So its function kind of is more towards apart from puberty, it's towards, the last few decades of life. Then let's look at the medulla, which is the central part of the adrenal gland, connected to the sympathetic nervous system, and it produces hormones which are collectively called catecholamines, of which epinephrine and norepinephrine are the two types, of which 80% produced is epinephrine, 20% is norepinephrine. Most of their actions are pretty similar, just that epinephrine tends to act more on the heart and the bronchial musculature. Norepinephrine tends to act more on the blood vessels. But otherwise, most of their actions are pretty similar. So it's just like the sympathetic nervous system, which means they cause an increase in heart rate, they cause vasoconstriction, so they increase the blood pressure by raising peripheral resistance. They increase blood sugar levels also, because during times of stress, you want your blood sugar to be high so that, you can produce ATP from that. Cause bronchiolar dilation, so they help you to breathe better during times of fight, flight. Which is why, as I said, if someone has asthma, then you give them epinephrine. So it helps to dilate their bronchi. They increase your metabolism. So you produce more heat. So in other words, it acts pretty much in a fight, flight, fright response. They also cause pupillary dilation. They increase in sweating. Because remember, the sympathetic nervous system supplies the sweat glands. So you'll see that if there's a tumor in this area, that you will have all the effects of increased epinephrine or epinephrine production. So let's just review the adrenal gland.
Hi, in this video I'm going to talk about adrenal gland function. So let's start off by talking about where the adrenal glands are located. Here are the kidneys, and they're situated in the abdomen. This is the left side and the right side. And notice the left is a little higher than the right. Now, on the left kidney and the right kidney are these two little hats, and they're called the adrenal glands. Now let's have a look at the structure of an adrenal gland. The adrenal gland is made up of 3 layers of cortex, and then an inner medullary layer. The most outer layer is the zona glomerulosa. The next is the zona fasciculata. The third layer is the zona reticularius. And then the adrenal situated in it. These 3 layers make up the adrenal cortex. Now I want to have a closer look at a section through the adrenal gland. So here are those 4 layers. I'll just label them G, F, R, and M. Now they each produce different hormones. Now the zona glomerulosa produces aldosterone. Fasciculata produces cortisol. The reticularis produces sex steroids. And the medulla produces epinephrine and or adrenaline and noradrenaline. That's the same thing. Now, epinephrine and norepinephrine are signals of the fight-flight response. The sex steroids are important for reproduction. Cortisol is normal. And aldosterone is important in water retention. Now let's have a look at their control. Calorie release is very simple by sympathetic action. So it's controlled neurally. The rest are controlled hormonally. ACTH, or adrenocorticotropic hormone, releases cortisol from the fasciculata. It also has another effect on the reticulum in releasing sex steroids. ACTH is from the pituitary. Angiotensin-2 causes the release of aldosterone, and it's part of the angiotensin-aldosterone pathway. And that's an overview of the adrenal function.
So that was a nice quick review on, the entire adrenal gland. And the way you're going to remember, I know students always like some acronyms of which zone comes first, is, if you remember, glomerulosa, fasciculator, reticularis, and then you know the medulla is inside. So the way you can remember is girlfriend's rule. Okay, so that's a good way to remember. Okay, now let's just review some of these. Which of these would not increase blood pressure? Okay, couple more. I think someone's not recording. Okay, very good. Yes, atrial natriuretic peptide. That's the one which will not cause vasoconstriction, hence won't raise blood pressure. So here let's look at the stress response, which is rather important. So during short-term stress, when you have stress and then you want the effect to just last for a short time, probably 20 minutes or so, at that time it is the adrenal medulla by means of catecholamines that is stimulated. So you can see if there is stress, just a little bit of stress, nerve impulses come, they travel down the hypothalamus, go to the lateral horn of the spinal cord from which the sympathetic neurons begin, the preganglionic sympathetic, which come and synapse here on the adrenal medulla, which produces those catecholamines. And then you can see all of this happens, the blood pressure, bronchioles dilate, liver converts glycogen to glucose. That's your glucose levels go up so that your tissues can get that glucose for metabolism. Metabolic rate rises, all of that happens. Long-term stress, you can see at that time, if someone has continued stress for a very, very long time, that comes through the corticotropic releasing hormone, comes into the anterior pituitary ACTH, that then causes secretion from the adrenal cortex, especially the zona fasciculata. Because this is stress, it can also stimulate the zona glomerulosa. So then you have the effects of aldosterone and cortisol release. So you can see you tend to feel a little bloated, your blood pressure rises at that time, and then because of the cortex you can see proteins and you break down more proteins and fats to produce glucose. Your blood glucose levels increase, your immune system is depressed. So you can see many people who are under long-term stress often fall prey to a lot of infections. And, it happens to you guys during the time of exams. When you're having exams, you're a bit stressed out. So you do kind of fall prey to colds and coughs and other infections at that time. Also, the adrenal gland also makes at this point, it also kind of increases the secretions from your sebaceous glands in stress. That's why people, when they are stressed out, do tend to break out with acne also. And so let's look at the stress response.
The stress response. In stressful situations, the body switches on its autonomic nervous system and neurobiological processes in an attempt to make homeostasis prepared for its reaction to stress. In the brain, the hypothalamus is connected to the pituitary gland. The hypothalamus, stimulated by the sympathetic nervous system, releases the hormone corticotrophic CRF. The CRF aids the pituitary gland to release the adrenocorticotrophic hormone, ACE. This in turn alerts the adrenal glands. The adrenal glands are on top of the kidney. The ACE from the pituitary gland stimulates the adrenal cortex to release cortisol. At the same time, neurons in the hypothalamus signal the medulla to epinephrine, adrenaline, and norepinephrine, noradrenaline. These hormones the body hyperalertness.
Hormones like TSH, and then CRH, ACTH, and adrenal cortex, cortisol. Okay, so it's important to kind of know that chain well. Let's look at some clinical conditions. The first one, when there is hyposecretion of the adrenal cortex, especially involving the zona, glomerulosa, and fasciculata. So there is mineralocorticoids and glucocorticoids are not being secreted. So here the person is terribly dehydrated because sodium cannot be reabsorbed by the body. So water also can't be reabsorbed. So they tend to kind of push sodium and water out of the body. They tend to go into dehydration. Also because glucocorticoids, remember one of their actions was to maintain your blood pressure because it kind of sensitizes your body's blood vessel receptors to catecholamine. So that's not there. So these people have hypotension and they can actually go into a crisis mode. So this is one of those dangerous things that happen. So you have to give them steroid hormones, you have to give them over and above what the body is producing. The opposite to this, or somewhat opposite to this, is when there is hypersecretion of the zone, just the zona fasciculata. It kind of forms a syndrome. So this is known as Cushing syndrome. Now this could be if there's a tumor in the adrenal cortex and that is causing increased glucocorticoid formation. Or it could be a tumor of the pituitary gland where there is increased ACTH formation. If there's increased ACTH, what will happen? It'll keep stimulating the adrenal cortex to go on producing cortisol, and whenever there's a tumor does not react to the feedback mechanism. So it kind of just does what it wants to do. So their feedback won't happen. So whenever there's increased ACTH production due to a pituitary tumor, that part is called Cushing's disease. You don't need to know the difference, but I just want to tell you. And there are other areas of the body also which actually can produce ACTH. The liver, lungs are some of them. So there may be sort of tissue present in these areas which are kind of forming ACTH, which is not regularly formed from these organs, but now these have begun to form. So you can have Cushing syndrome because of that. Or it could also be when somebody is being given steroids and, they are on steroids for a long time. So then the effect of that elevated levels of steroids ends up in them having Cushing syndrome. So now whatever effect you see is because of increased cortisol levels in the blood. So one of the first things that happens is that there is fat distribution is kind of reorganized. So the fat tends to be towards the middle of the body, which is centripetal. So it kind of is present at the back, around the abdomen. And the legs and hands kind of look very, very thin. So it's centripetally, that means away from the body, or centrifugally, away from the body, they look very thin, but in the center of the body, they are very, very fat. So fat goes on the back of the neck, so they have a little buffalo hump. It's deposited around the face, so their face kind of looks really big and moon-faced, very, very round. They have a lot of fat in the abdomen, so they have a huge kind of belly there. And on the arms and the legs kind of look really thin. So we often say this looks like a lemon on a toothpick. So, so they look really, really thin and scraggly. The other things that happen, because remember, increased cortisol, what does it do? It causes breakdown of protein. So these people, because of that increased protein breakdown, keratin is protein. So the skin becomes very thin. So their skin has what are known as striae. When pregnant women have those little kind of lines present on the abdomen and the abdomen swells, that's called striae. But in these people, again, it is because of breakdown of the keratin. They're not producing enough, keratin is being broken down. The hair also becomes extremely straggly. The immune system is depressed. So these people kind of have, they fall prey to infections. They also have bone loss because bone is removed from, calcium is removed from the bone, so whenever there is increased cortisol, so they have a whole lot of these problems. The other condition is aldosteronism, where there is hypersecretion of mineralocorticoids, where you have hypertension. So this is spelled wrong. So they have hypertension because now you're absorbing more sodium and with it water, and this is in the extracellular fluid. So it will be in the blood, so your blood pressure goes up, so there's hypertension. Also, there'll be edema because it's present on the outside of the cells. So these people look edematous. So this is to do with the adrenal, the zona fasciculata and glomerulosa. Then in the zona reticularis, if there is a tumor of the zona reticularis where you have hypersecretion of gonadocorticoids, most of the time it affects the women more than it does the men, because men as it is produce testosterone, so it doesn't affect them that much. Most of that time the women look more masculine, so that's what is called virilization of females. So these people will have increased hair in the body, which is hirsutism. So, they may grow something like a beard. The clitoris also may enlarge and look like a small penis. So this is known as the adrenogenital syndrome. Then the other condition is called pheochromocytoma, which is hypersecretion of the adrenal medulla. So here catecholamines are secreted, so all their actions will be magnified. So, vasoconstriction will happen. They will their metabolic rate will increase sweating. So all of these things will be seen in someone with pheochromocytoma. So this is a tumor of the adrenal medulla. Now here, this is a person with Cushing's disease. So you can see there's this buffalo hump. Look at the fat around the middle of the body, whereas you can see the arms are looking rather thin. So here's this buffalo hump. You can't see her face, but, typically moon-faced. There are a lot of fat deposited in the abdomen, and that kind of stretches it. And so you have these little, where the skin the collagen kind of breaks, you can see these little striae. Very, very thin skin, like I mentioned, because, there's protein breakdown. Keratin is a protein. Similarly, hair also becomes very straggly. And because the immune system is depressed, automatically there is poor wound healing. In these people, they also have hypertension because, again, if there's increased cortisol, the blood vessels are more sensitive now. You have more of it, so they're very sensitive to catecholamines, so the blood pressure goes up. And remember, one of the effects of cortisol was to increase blood glucose. So they have something known as steroid diabetes. So they might become diabetic at this point. So let's look a little bit about Cushing's disease.
Sometimes we're concerned about the body making extra steroids, and a term is called Cushingioid or Cushing's disease. What is that?
Dr. Kaplan, many times people come to me and are concerned that their child may be gaining weight because they may have a condition where they're using too much cortisol. Cortisol is produced in a triangular-shaped gland called the adrenal gland, and it's important in its life-saving system of preventing stress from the body. This cortisol is produced in very, very discrete amounts under a very control. It is exceedingly rare to have a condition where the body makes excess cortisol, and one of the easiest ways that a primary care doctor can make sure that that's not happening is to ensure that the child's growth is normal. Should the child be growing abnormally, that means not growing tall enough, and certainly that could be a condition where excess cortisol is made. However, really, there is a condition where excess cortisol is made. The child would seem to be gaining weight out of proportion to what they should be, and at the same time not growing well. In this situation, it's oftentimes found a tumor in the adrenal gland or a tumor in the brain causing the adrenal gland to make too much cortisol. And this is best treated through a surgical approach with consultation with a neurosurgeon.
Okay, let's look at this question. This person suffers from pheochromocytoma. What do you think you're going to see in this person? Hypertension, yes, very good. Okay, let's stop here.